Becoming a Safe Injection Champion, a program sponsored by the Nebraska Department of Health and Human Services Division of Public Health. The Safe Injection Champion program is a training program for healthcare professionals about safe injection practices. This program was funded from an epidemiology and laboratory capacity grant. Nebraska Department of Health and Human Services is one of 10 federally funded partner states to promote safe injection practices in an effort to reduce infections caused by unsafe practices related to injectable medications and poor infection control. The objectives of this program are to relate the correct use of equipment used for injection administration, identify areas where medications may be mishandled, discuss correct processes for maintaining a clean or sterile environment for medication preparation or administration, identify areas where oversight or perceptions of cost saving may put patients at risk for unsafe practice, relate best practices for blood glucose testing and medication pen administration, and list 3 principles of outcomes research and quality assessment methods to the evaluation of pharmaceutical care. This web-based program is designed to be very flexible for the learner to complete the educational event in either sections or all at once. The content is divided into distinct sections, which will allow you to find your place if you need to stop and restart the program at a later time. Just record the slide number or section you ended and restart the program where you left off until you have completed all 5 sections. Section 1. What it means to be an injection safety champion. Let's start this first section by looking at the structure of the complete course. As a safe injection champion, you will have the following responsibilities. Become updated on the latest safe injection practices by successfully completing the Safe Injection Champion course. Audit the injection practices at your facility on a routine basis. Spread new information, ensuring the competency of the healthcare workers in your place of employment. Stay updated on safe injection practices, and we will help you with this by distributing practice changes as they occur. The very first step is to complete the Safe Injection Champion course. The Safe Injection Champion curriculum is applicable to all types of healthcare providers. The curriculum includes key points for injection safety, including safe disposal. The benefits of having a safe injection champion at your facility are recognition to your customers of using a critical patient safety practice, having a knowledgeable employee on staff who can monitor safe practice, intentional routine auditing a practice by an employee for patient safety, receiving new information as practice changes and best practices are shared, and access to subject matter experts on injection safety. Please review the following course material and complete the competency test at the end. Upon successful completion of the competency test, you are eligible to apply for continuing education credit as described on the Nebraska DHHS website. Your next step will be to complete an initial audit of injection practices at your facility. After the initial audit, we ask that you establish a regular audit schedule of injection safety practices in your facility and share your results with your staff to educate and ensure safe injection practices are followed routinely. If you have any questions about the audit or injection safety practices, please contact the Safe Injection Coordinator listed on the Safe Injection Champion Healthcare Associated Infections webpage on the Nebraska DHHS website. Thank you for enrolling in the Becoming a Safe Injection Champion program. And now I would like for you to hear from the patient's perspective on how the work you will be doing is so vitally important.
Dear Sir or Madam, you have been exposed to hepatitis C, hepatitis B, and HIV through unsafe injection practices while accessing healthcare services. These were the opening lines of a letter I received from Nebraska Health and Human Services in 2002. I am Evelyn McKnight, and I contracted hepatitis C during chemotherapy for breast cancer because a nurse reused syringes. I am one of 99 Nebraskans who was infected. We make up the largest healthcare-associated outbreak in U.S. history. The suffering caused by hepatitis C was so much worse for me than what I endured because of cancer. I think it was that way for many of my neighbors. In fact, 6 of our 99 have died not from cancer, but from hepatitis C. And it was all completely preventable. Unsafe injection practices continue to cause disease transmission in all parts of the United States, in all types of healthcare settings. But it doesn't have to be this way. By learning and using the basic infection prevention practices in this video, you can be assured that you won't be the cause of disease transmission. And you can be a mentor and an advocate for injection safety among your colleagues. Safe practices are important for the well-being of everyone, because we are all patients at some time. So the safe practices that you use and model keep safe your neighbor, your child, your parent. It keeps you safe from healthcare-associated disease. We can't know how many lives you will save because of your commitment to safe healthcare. Thank you so much for your passion for safety.
Section 2. Why safe injection practices must be followed. Unsafe injection practice leads to outbreaks and more. They can result in very serious consequences. Hundreds of patients infected in a variety of settings, mostly at this point in time we have seen in outpatient settings. Thousands of patients have required blood-borne pathogen testing after potential exposure. There have been lawsuits, criminal charges, healthcare professionals losing their license, and actual closing of facilities. You can see examples on the next slide from the updated outbreaks and notification list. This link on this slide is available for you to look at any point in time to see, unfortunately, as this list continues to be updated. Here is the listing of some outbreaks that have resulted in either patient notification and some with documented transmission of blood-borne viruses. As you can see from this listing, many people's lives were directly affected. Here are some of the headlines from across the country in response to breaches, disease transmission, and outbreaks. These types of events erode public confidence and make patients less likely to seek needed preventative care services if they perceive health care as being unsafe. Here's another example of an outbreak resulting in legal action as a result of an unsafe care practice given to a very vulnerable cancer patient. This clinic was closed. 16 patients resulted with bloodstream infections. 470 patients were notified and advised to undergo blood-borne pathogen testing. It was a clinic in southern Mississippi, gave cancer patients less chemotherapy or cheaper drugs than they were told, and reused the same needles on multiple patients. This slide tells you about contaminated injection equipment and Sharp's injuries as being a major method of transmitting hepatitis B and C viral infections. The mode of transmission is frequently with injection equipment, and you can also see the United States statistics of transmission of hepatitis B and C, which are involved with injection safety practices. This slide shows that hepatitis B is a hardier virus than other blood-borne pathogens, and it has a higher risk of transmission. Hepatitis B has prolonged survival, greater than 7 days in the environment and on medical equipment. Hepatitis C is less stable in the environment than hepatitis B, but some viable virus has been recovered up to 9 weeks later in used syringes. HIV, or human immunodeficiency virus, can last several days in a syringe and is not near as stable in the environment. Not only is there viral transmission from unsafe injection practices, but here is a sampling of several bacterial pathogens that were transmitted from documented outbreaks. Some of these were discovered by astute healthcare workers that saw a pattern from patients that they were treating for infections, or patients and families recognized poor practice when they saw something, they said something. Is this a growing problem? There's a growing reservoir of infected individuals who can serve as a source of transmission to others if safe injection practices and other basic infection control precautions are not followed. Among hepatitis B and C cases, when interview information was available, between approximately 1/3 and 2/3 have unknown or unidentified risks. Among patients aged 55 years or older, the portion of new infections, which are likely attributable to injections excluding vaccinations, was 37%. Furthermore, approximately 8% of cases could be attributed to hemodialysis. The prevalence of hepatitis C infection is highest amongst persons born between 1945 and 1964. Members of this cohort will progressively come into more contact with the healthcare system as a natural consequence of aging, as well as to receive specific hepatitis C associated care. Thus, there is a growing reservoir of infected individuals who can serve as a source of transmission to others if safe injection practices and other basic infection control precautions continue not to be followed. So here is our first knowledge check. You will see these throughout this program to reinforce important points. I will pause after reading the slide to let you consider the correct answer before going forward, and the correct answer will be highlighted with the rationale for the correct answer being displayed. So our first knowledge check is unsafe injection practices can result in A, outbreaks, B, lawsuits, C, facility closures, D, criminal charges, or E, all of the above. Correct answer is E. Unsafe injection practices harm patients, families, and facilities where the breach occurred. There is always time to practice safety. Section 3. What are safe injection practices? Injection safety represents the intersection of three major components of an overall safety program: medication safety, healthcare-associated infection prevention, and employee safety. The basics of infection prevention begin with the use of standard precautions. Standard precautions include hand hygiene, use of personal protective equipment or PPE, respiratory hygiene and cough etiquette, safe injection practices, and safe handling of potentially contaminated equipment or surfaces in the patient environment. As you can see, safe injection practices are one of the standard precautions that are expected for healthcare workers to use with every patient. So let's look at what is a safe injection. A safe injection requires measures taken to perform injections in an optimally safe manner for patients, healthcare personnel, and others. And a safe injection does not harm the recipient, does not expose the provider to any avoidable risks, does not result in waste that is dangerous for the community, and includes practices intended to prevent transmission of infectious disease between one patient and another, between a patient and a healthcare provider, and prevents harm such as needle stick injuries. Where are the risks? The main risks for injection safety include injection equipment, medication containers, medication preparation, medication storage, sharp safety, drug diversion, and point-of-care devices. We will use this as our outline for this program. Section 3A, Injection Equipment. One major risk is how injection equipment is used. The guiding principle is, as this poster displays, one needle, one syringe, used one time. That's the only way that we will achieve zero infections. Here is an example of an unsafe practice that occurred that required patient notification. A medical assistant was administering flu vaccine from the same syringe to more than one patient. Children between the ages of 6 months and 35 months were put at risk. Patients had to be notified and bloodborne pathogen testing was advised. Remember, needles and syringes are used for only one patient. This includes manufactured pre-filled syringes and cartridge devices such as insulin pens. Safe injection practice research has shown that, first of all, when you're thinking of this particular subject, you think it doesn't happen at my facility, but we found that isn't to be true. A recent study by Kossover and Smith from a panel of physicians and nurses, over 690 of them surveyed, responded that 12% of physicians and 3% of nurses indicated reuse of syringes for more than one patient. 5% of physicians indicated this practice usually or always occurs, and a higher portion of oncologists reported unsafe practices in the workplace. Double dipping is a practice that has resulted in many outbreaks. Here's an example of an outbreak that occurred from double dipping. This is when a syringe that has been used to inject IV medication into a patient is reused to enter a medication vial that was used for subsequent patients. In this particular outbreak, over 2,000 patients had to be notified and bloodborne pathogen testing was recommended. Medication vials, according to the CDC, should be entered with a new needle, new syringe, even when obtaining additional doses for the same patient. This is a question that is brought up to me several times. Can I change only the needle? This is frequently asked, and the picture on the slide is one that was drawn up to demonstrate from an actual outbreak how hepatitis C was transferred from one patient to the next. The beginning of the picture shows a clean needle and syringe being injected into a sterile vial, where then after the needle and syringe was used on a patient that was infected with hepatitis C, just the needle was changed. But remember, we deal with the unseen. There was still hepatitis C virus in that syringe. That same syringe was used to draw up a second medication with a sterile needle on it, but the same syringe. So then when someone else came with a clean syringe and needle to that vial that had been previously used, they drew out contaminated medication that also had hepatitis C virus in it. Cartridge-style syringes. This unsafe practice also can lead to dosing errors, drug mix-ups, and other types of medication errors, particularly because the prepared syringes are often unlabeled or the medications are entered with another syringe using the cartridge as a medication vial. The cartridge is not designed for this use and can contaminate the medication. Saline and heparin syringes are also common medication equipment. Do not dilute or reconstitute IV push medications by drawing up the contents into a commercially available pre-filled flush syringe. We see saline and heparin syringes all over in clinic rooms and emergency rooms because they're a very commonly used device. But pre-filled syringes of saline and heparin are regulated by the U.S. Food and Drug Administration as devices and not as medications. They are approved for flushing of vascular access devices and are not approved for reconstitution, dilution, or subsequent administration of IV push medications, and such use is considered off-label. Pre-filled flush syringes are not tested for product safety when used in this manner, and warnings intended to limit the use of pre-filled syringes appear on the syringe barrels, clearly stating IV flush only. Here's another unsafe practice alert where a hospital telemetry unit nurse had been reusing saline flush pre-filled syringes in the IV lines of multiple patients. The nurse frequently was seen to be leaving a partially filled syringe near a computer workstation. The nurse reported reusing syringes during the previous 6 months, believing that this was a safe, cost-saving measure, so long as she provided no fluids when she withdrew the syringe from the patient. This caused many patients to be notified and tested for bloodborne pathogens. Medication pen administration is another type of injection safety equipment being used more and more. Medication or insulin pens are designed for reuse on a single patient. They should be labeled with the individual's name on the barrel itself. Do not store pens with the needle still attached. Change the needle after every administration, and never store pens for multiple patients together. An outbreak occurred with medication pen when a diabetes educator used that insulin pen for more than one patient. 2,345 patients had to be notified and recommended to undergo bloodborne pathogen testing. So here are some very dangerous misperceptions that changing the needle makes a syringe safe for reuse. Syringes can be reused as long as an injection is administered through an intervening length of IV tubing. Or if you don't see blood in the IV tubing or syringe, it means that those supplies are safe for use. Once they are used, both the needle and syringe are contaminated and must be discarded. Here's another knowledge check. A syringe may be reused if A, the needle is changed, B, the medication was injected into an IV line and not directly into the patient's skin or vein, C, a syringe should never be reused, D, if no blood is seen, it is safe to reuse a syringe. As we've discussed, a syringe should never be reused. Each time a syringe or needle is reused, a pathogen can be transmitted to a patient or can contaminate a medication vial. Section 3B, Medication Containers. The first type of medication container we will discuss is a single-use, single-dose vial. The definition is a liquid medication intended for parenteral administration for use in a single patient, for a single case, single procedure, or single injection. They may be vials, ampules, or intravenous bags. Size does not matter. They can be big and be single dose because there's no preservative in them. Single-use or single-dose containers, as we've said, size and volume does not matter. The sole criteria is if the manufacturer's label says single-use. They typically lack an antimicrobial preservative, and the rubber septum must always be disinfected with alcohol prior to entry and allowed to dry. The cap on top is simply a dust cover. The septum is not sterile when you initially take the cap off. Always enter a vial with a new sterile needle and a sterile syringe and discard immediately after use. Single-dose medication vials cannot be used for a second patient or during a second case, be returned to a medication cabinet if punctured, have remaining medication withdrawn and pooled with partial contents of other vials, or have a needle left in the septum of the vial for multiple draws. These are just a few reminders and a few important points. The next type of container we will discuss is the multi-dose vial. A multi-dose vial is a vial of liquid medication intended for parenteral administration, injection, or infusion that contains more than one dose of medication. Multi-dose vials are labeled as such by the manufacturer and typically contain an antimicrobial preservative to help prevent the growth of bacteria. The preservative has no effect on viruses and does not protect against contamination when healthcare personnel fail to follow safe injection practices. Handling of multi-dose medications. Multi-dose medications should be dedicated to a single patient whenever possible. Always be entered with a sterile needle and sterile syringe. Have the rubber septum disinfected with alcohol prior to each entry and allowed to dry. Have a label with the date of initial entry. Be discarded within 28 days of opening or according to the manufacturer's instructions, and always be discarded if sterility is in any way compromised. This is an outbreak that was the largest outbreak resulting in direct infections documented for a number of years. This occurred at a hematology oncology clinic in Nebraska in 2002. A gastroenterologist reported 4 patients with recent hepatitis C infection to the health department. all received chemotherapy at the same clinic. Close to 1,000 patients were tested and 99 were infected with hepatitis C. The same syringe was used to draw blood from the patient's central line and then to draw a catheter flushing solution from a 500 cc saline IV bag used on multiple patients. Here's our next knowledge check. If a single-dose vial has enough medication for 2 doses, it is appropriate to save the second dose for another patient. True or false? Single-dose vials do not have a preservative and should never be used for more than one patient. Section 3C, Medication Preparation. Another guiding principle along with standard precautions is that aseptic technique must be used when you handle, prepare, and store medications and injection equipment supplies, such as syringes, needles, and IV tubing, to prevent microbial contamination. Aseptic technique includes using a new sterile syringe and sterile needle to draw up medications while preventing contact between the injection materials and the non-sterile environment. Proper hand hygiene before handling medications, and disinfecting the rubber septum with alcohol prior to piercing it. Scrubbing the hub. Scrub that access port with an appropriate antiseptic. Most of the time, it's most convenient to use an alcohol pad, but chlorhexidine, povidone iodine, or an iodophor can also be used. It requires friction, and we need to wait at least 10 seconds to allow the diaphragm to dry before inserting any device into the vial or accessing the medication. And access a port only with a sterile device. Here's a knowledge check. Needleless connectors, A, can be a source of contamination, B, must be scrubbed prior to accessing the line, C, it is important to allow 10 seconds of drying time prior to access, D, all of the above. Needleless connectors can allow pathogens to enter a line if not cleaned prior to attaching a syringe. Allowing drying time prevents entry of cleaner into the IV line or vial. Where you prepare medications matters. Do not bring medication to the immediate patient treatment area. The rationale is it decreases that temptation to reuse a vial with a contaminated syringe. If brought to a room, it is best practice to discard. What does a medication preparation room look like? It should be a designated clean area, well lit, contains a refrigerator which has a refrigerator log to make sure that the temperature inside that refrigerator stays at the appropriate temperature. There should be no food. There should be the ability to do hand hygiene. There should be nothing on the floor. It should have a sharps container. It should have limited access and must be separate from used supplies and equipment such as glucose meters. Here's a couple of pictures of environmental services in a medication preparation room which were not kept clean. You can see it's very easy to get a little bit of blood contamination if used equipment is brought back to a clean area. And here's a reused vacutainer holder in contact with gauze that was going to be used on another patient. A frequently asked question from the CDC website addresses safe injection practice if your facility requires barcode scanning of vials prior to administration. If you do require barcode scanning of medication vials, that also should occur in dedicated medication preparation areas, but sometimes that's not possible because you need to do this in a patient room. If that's the case, then that vial should be dedicated for single patient use only. The patient should be housed in a single patient room. It should be in a designated clean area in that room that is not adjacent to a potentially contaminated source, such as a sink or used equipment. Remember, when you start a sink, the water comes down from the faucet into the drain area and splash occurs. And so there should not be any sterile equipment within that splash zone, and normally that's within 3 feet of a sink. Following preparation, the vials should be stored in accordance with manufacturer's instructions in a manner to prevent inadvertent use for more than one patient and/or cross-contamination. Knowledge check. Key points for a medication preparation area include all but A can be a mixed-use area, B must have a sharps container, C must have a means for hand hygiene, and D must have limited access. Medication preparation must be separate from other patient care areas to ensure the security of medications and equipment and to minimize distraction to individuals preparing to practice aseptic technique, proper use of equipment, and correct dosing. Part of preparation includes proper use of personal protective equipment or PPE. The World Health Organization guidance on use of gloves for injection safety include wear non-sterile single-use gloves when performing venipuncture or venous access injections. Gloves are usually not needed for routine intradermal, subcutaneous, or intramuscular injections. However, there may be times a provider chooses to wear them if blood exposure is expected. Change your gloves if soiled, torn, or punctured. Do not wash or decontaminate gloves. After treatment, remove before leaving the area. And do not wear gloves outside of the treatment area when charting or in hallways, and always wash your hands after glove use. Preparing IV bags in advance. The United States Pharmacopoeia, or the USP, convention states 1 hour time limit from when you prepare or spike an IV bag until beginning of administration. This precludes microbial growth in the event of contamination because organism replication can occur within 1 to 4 hours. Multiple syringe administration. The best practices for when you have a lot of syringes to prepare. And I think about the times that I have had to do this. This has been flu clinics, this has been TB testing time. But best practice is prepare a single syringe and administer at the bedside or to, if it's an outpatient clinic, that patient before preparing the next syringe, or label each syringe as it's being prepared prior to any additional syringes, and bring only one patient's labeled syringe to the bedside for administration. Adding 2 medications. When preparing more than one medication in a single syringe for IV push administration, limit preparation to the pharmacy. You want to limit as a best practice this to the pharmacy because there's a real risk of drug incompatibilities, and normally that isn't something that the average healthcare worker is going to know. So any compounding of more than one drug in a single syringe should be carried out in a pharmacy and a USP-compliant clean room. This is a frequently asked question from the National One and Only campaign answered by the subject matter experts. What about numbing a large area of skin or incremental doses of intravenous medication? The safest practice is for a syringe and needle to be used only once to administer a medication to a single patient, after which the syringe and needle should be discarded. As we've said before, this is our guiding principle. But when not feasible, reuse of the same syringe and needle for the same patient should occur as part of a single procedure with strict adherence to aseptic technique. In such situations, it is necessary that the syringe never be left unattended and that it be discarded immediately at the end of the procedure. Labeling. Label all clinician-prepared syringes of IV push medications or solutions unless prepared at the bedside and immediately administered. Clinicians have been unexpectedly interrupted or distracted while carrying an unlabeled syringe to the bedside, thus prone to a mix-up. An ANA study identified that the top reasons nurses do not label syringes included Concerns that the labels may cover the measurement gradation on the syringe barrel, impair the ability to accurately check the dosage, and lack of a suitable label. The Joint Commission National Patient Safety Goal requires practitioners to label all medications, medication containers, for example, syringes, medicine cups, basins, or other solutions on and off the sterile field. Best practice for labeling is to provide units with blank or printed, ready-to-apply labels, sterilize labels when needed. Immediately discard any unattended, unlabeled syringe containing any type of solution, and never pre-label empty syringes in anticipation of use. Medication vials also need to be labeled. Every medication should have a manufacturer's expiration date already on the vial. However, the person preparing a multi-dose vial needs to put a beyond use date on the vial. A beyond use date is the date after which an opened multi-dose vial should not be used. Beyond use date should never exceed the manufacturer's original expiration date. Unless indicated by the manufacturer, the beyond use date is 28 days from the day that the vial is opened. An appropriate label should have patient identification on it. You should be able to see the medication name and dose, the initials of the person preparing, the appropriate date, so far as beyond use date and expiration date. Label placement. Make sure that the label is placed on the actual vial and not the box. This has been another place where the wrong vial has been put in the wrong box. Knowledge check. If the manufacturer's expiration date is less than 28 days from the beyond use date on a multi-dose vial, the vial A may be used until the beyond use date, B must be discarded at the manufacturer's expiration date, C not used if the vial expires this close to expiration, and D may be used only once and then discarded. The beyond use date should be placed on a vial after it is used because pathogens can multiply in a multi-use vial once it has been punctured. The manufacturer's expiration supersedes the beyond use date to ensure effectiveness of the medication. Section 3D, sharp storage. Another area to evaluate to ensure safe injections is the storage of equipment used for administration. Best practice is for sharps and medications to be stored in a centralized area. This minimizes the risk of reuse. A secure area may be described as an area where the staff is providing patient care or staff is present and effectively ensures that access to the area or storage device is restricted to authorized individuals, and patients and visitors are not allowed access without the supervision or presence of a healthcare professional. Organizations are expected to implement a process to identify safety and security risks associated with the environment of care that could affect patients, staff, and other individuals. Conducting a risk assessment is a helpful way of identifying risks associated with various options being considered to ensure safe storage of syringes and needles. Some principles there are don't supply sharps in individual clinic rooms because that minimizes the risk of syringe, needle, or medication vial reuse. Unused supplies should be stored in only clean areas separate from used equipment. Check for expiration dates and make sure that your stock is rotated. Do not carry supplies in pockets, and then storage should be kept secure to protect from tampering or theft. And this is a good way of looking at this is considering a risk assessment. To prevent contamination, we need to store supplies away from sinks and under sink cabinets. Use individually wrapped items instead of loose in glass or metal jars or drawers where you reach in and say take out a cotton pad or cotton ball and your fingers are touching other cotton pads or gauze pads. Never store supplies in external cardboard packing boxes. Remove the packing box in a designated dirty area and then transport supplies in a clean manner to where they will be stored. Remember, an external packing box has been on the sides of the inside of a semi-truck, which is not a clean area. So that needs to be removed and just the clean boxes brought into the clean area. Keep drawers, trays, and cupboards and closets clean and dust-free. And do not remove packaging from syringes and then store, as seen in this picture. Why that is because, first of all, that packaging acts as a dust cover to keep that syringe clean. And second of all, it's a visual cue to anyone getting ready to use a syringe that this syringe has not been used. Knowledge check. Injection safety supplies can be stored A, under sinks, B, external cardboard containers, C, removed from wrappers and packaging, D, none of the above. Injection safety supplies must be kept clean and free from contamination, dust, and liquids that may penetrate the packaging. Section 3E, Sharps Safety. This section discusses safe use of sharps to prevent injuries from injection equipment. To prevent injury, sharps need to be disposed of safely. They need to be disposed of only in approved containers. Do not recap or bend needles prior to disposal. Replace containers when the fill line is reached. Secure sharps containers to prevent spilling. Provide containers within easy reach of where they are used, and make sure that container is easily visible in the room. Occupational Safety and Health Administration, or OSHA, creates the standard for sharps containers. They must be functional, which means that they are durable, closable, resistant to opening after final closure, puncture resistant, leak resistant, and that you have a sufficient number and size of them. They should accommodate the largest sharp used in an area, and stable on a horizontal surface, and always have a biohazard label on them. They should be accessible, conveniently located at the location of use, and that includes places like crash carts or in the laundry. They should be visible and at a vertical height where you can see the opening. Accommodating, routinely replaced and not allowed to be overfilled. Some inappropriate places to place a sharps container would include corners, backs of doors, inside cabinet doors, areas over which people may sit, near light switches, where a container subject to impact or dislodgement by pedestrian traffic from the device being hit could occur. Here's some examples of medications pens that are used and how we need to look at the size of a sharps container that is used in an area, because a lot of the medication pens are much larger than the fourth example there of simply an insulin syringe. The circumstances and timing of when percutaneous injuries involving hollow bore needles that we use frequently occur, needle stick injuries from insertion or removal of the needle 27% of the time. So this is an especially vulnerable time. Be careful in handling a needle. The OSHA bloodborne pathogen standard requires safer medical devices such as sharps with engineered sharps injury protection and needleless systems are an effective engineering control and must be used wherever possible. And this is a picture of how some of those engineering controls can occur, either using needleless devices or retractable needles or covered needles, because the CDC estimates that healthcare workers sustain nearly 600,000 percutaneous injuries annually involving contaminated sharps. So one of the things when you're doing your assessment you need to look at is, where do you have sharps? Are they in your clinic rooms? Are they in your clean utility room, clean storage closets, your resident rooms, medication carts, medication rooms, IV trays? Look for areas of risk, and it shows that a lot of times we don't report needle stick injuries. This is an example of a study that was done of 72 home health care nurses, and 13% of the home health care nurses experienced 10 needle sticks in the 12-month period before the study, and only 4 needle sticks were actually reported to their employer. So, best practices that we've talked about along the way are: use single-dose vials in place of multi-dose vials, correctly label all your syringes and vials when used, never re-enter a syringe that has been used, that's double dipping, and discard outdated medications. So let's again review safety steps for successful administration. Before administration, read the label. If a single-dose vial has already been accessed, throw it away. If a multi-dose vial has been accessed, make sure it's not past the beyond use date. When in doubt, throw it out. During administration, use aseptic technique. Use a new needle and syringe for every injection. Hand hygiene before handling medication. Disinfect the vial by rubbing the diaphragm with alcohol, even for newly opened vials, and draw up in a clean medication preparation area. After administration, discard all used needles and syringes immediately, and single-dose and multi-dose vials in the patient treatment area in designated containers, and discard prepared or open syringes involved in emergency situations. So it's not just the right thing to do, it is required. OSHA has the authority to enact federal standards for safe or healthful employment and places of employment. A specific standard applies to needle sticks, injection safety, and the risk of acquiring the bloodborne pathogen. The standard is located at the link on your slide and should be reviewed. There are many regulatory and surveying agencies that have injection safety requirements. The Center for Medicare and Medicaid Services, or CMS, and agencies that survey for them, such as the Joint Commission and state health departments. There are other regulatory requirements that involve all types of healthcare facilities, such as in ambulatory care, the AAAHC, acute care, the CMS Hospital Infection Control Worksheet, and long-term care. There are several references also. So let's just look at what the Accreditation Association for Ambulatory Healthcare says, that infection prevention and control program reduces the risk of healthcare-associated infections and uses CDC or nationally recognized guidelines for safe injection practices. You need to have a written sharps injury prevention program, and it must be present in the organization. And then goes on to detail what exactly that written sharps injury prevention program must include. There is available for your use an ambulatory surgery center infection control surveyor worksheet, which is a good document for you to use to look if you work in an ambulatory surgery center to do your audit with to see if you're meeting these requirements. Also, the Center for Clinical Standards and Quality Survey and Certification Group, which is your long-term care group, has a section on injection practices and sharp safety. They ask that appropriate personnel receive training and competency validation that they're using injection safety procedures at time of employment, and then that training and competency validation on injection safety occur at least every 12 months. CMS also has a hospital infection control worksheet that you can use as for an audit. And here's one more knowledge check. The time of greatest risk of a needle stick from a hollow bore needle is A, during disposal of the needle, B, when passing the needle, C, when collecting a specimen, or D, insertion or removal of the needle. Remember, extra caution must be used at insertion and removal of hollow bore needles, as 27% of needle sticks occur at this point of use. Section 3F, drug diversion. The last portion of this section, of Section 3, is different than the rest because the exposure is usually to the patient from another patient in the topics that we've discussed already. Drug diversion is different, and the exposure is from a healthcare worker with a blood-borne infection and through contaminated equipment or supplies, which then expose a patient. There's been several, especially hepatitis C outbreaks linked to drug diversion by infected healthcare workers, and also bacterial outbreaks. Actions for the prevention of drug diversion can be divided into three main categories: prevent, detect, and respond. For prevention, healthcare facilities are required to have systems in place to guard against theft and diversion of controlled substances. All staff need to understand and comply with protocols, acting in ways to minimize unauthorized access or opportunities for tampering and misuse. Policies need to include items from ordering of controlled substances to wasting of unused supplies. Detect. Systems need to be in place which include active monitoring of pharmacy and dispensing record data, camera surveillance in high-risk areas, implementing a clearly defined process for controlling and accounting for keys, rules against sharing passcodes, utilizing barcodes for tracking, deploying secure and locked delivery carts, and using tamper-resistant packaging. Respond. For staff, this can be summarized as see something, say something. Appropriate response at the institutional level includes assessment of harm to patients or other healthcare workers, consultation with public health officials when tampering with injectable medication is suspected, and prompt reporting to enforcement agencies. One area of risk in doing things that are not standards of practice may be lack of oversight. Sometimes the culture at a workplace may not support an individual speaking up in a position they perceive to be in lower in authority when they see noncompliance. People like radiology techs, medical assistants, dental assistants, when they're working with physicians, may be uncomfortable with speaking up in fear of losing their position. But noncompliance may result in licensing board disciplinary action or malpractice suits. Correct equipment is not always available and utilized, and we need to speak up when it is not, because assurance from an employer or a supervisor that a practice is safe will not protect you. So respond by see something, say something to prevent an unsafe practice. Report events or near-miss events to facility risk management. Know your state requirements for mandatory reporting. Know your state or local health department, and also the requirements by regulatory or accreditation agencies. In the unfortunate instance where you believe a breach has occurred, the CDC has outlined a process to review. The process is available at the website identified on this slide. We need everyone to question and to be monitoring practice, and again, if they see something, say something. Add double layers of protection. Question medication preparation outside of a designated area. Question if you see a syringe removed from a pocket. Question when a syringe is removed from a needle. Question any unlabeled syringe or vial. Question all your locations about storage of injection equipment and medications. Knowledge check. If a physician gives direction to divide a single-use vial for multiple patients, that action can be completed and meets appropriate safety standards. True or false? Employer advice does not supersede safety standards of practice and places the employee at legal risk and the patient in harm's way. Section 4, Point-of-Care Testing. The next section has to do with point-of-care testing as a mechanism for bloodborne pathogen transfer. This is an example requiring patient notification and did cause infections in patients. At a health fair in New Mexico, reused fingerstick lancets exposed over 2,000 individuals, and in an assisted living in North Carolina, reused lancets and shared glucose meters resulted in 8 hepatitis B infections. All the residents were hospitalized, and 6 of them it was fatal. Best practices for use of blood glucose monitors include that they should be assigned to an individual and not shared. If the meters are shared, the device should be cleaned and disinfected after every use with an EPA-registered disinfectant per manufacturer's instructions. If the manufacturer does not specify how it can be cleaned and disinfected, it should not be shared. The CMS State Operation Manual has a section which describes that blood glucose meters can become contaminated with blood, and if used for multiple residents, must be cleaned and disinfected after use according to manufacturer's instructions, and staff must not carry blood glucose meters in pockets. CMS requirements include the cleaning according to manufacturer's guidance. Single-use monitors must be stored to ensure that they are used on the correct residents without cross-contamination from other equipment. And if the facility fails to clean and disinfect per device manufacturer instructions and are used for more than one resident, surveyors must cite this as a tag and utilize the guidelines to constitute an immediate jeopardy. Practices associated with hepatitis B transmission during assisted monitoring of glucose levels include use of fingerstick devices or insulin pens on multiple persons, failure to change or use gloves or perform hand hygiene between procedures, or failure to clean and disinfect blood glucose testing meters between use. Fingerstick devices. The recommendations for fingerstick devices include never use on more than one person and use auto-disabling single-use fingerstick devices for assisted monitoring of blood glucose. The CMS standard for fingerstick devices include that if they're used on more than one resident, again, the surveyors must cite this tag and utilize the guidelines for immediate jeopardy. The state survey agency must notify the appropriate state public health authority of this deficient practice. Personal protective equipment with point-of-care testing. You need to wear gloves during blood glucose monitoring and any other procedure that involves potential exposure to blood or body fluids. Perform hand hygiene before and after glove use. Avoid handling test strip containers with soiled gloves to avoid contamination. If you need a new test strip, discard your soiled gloves, perform hand hygiene, put on new gloves before obtaining a new test strip. Remove gloves between patient contact and include hand hygiene, again, before and after glove use, and dispose of sharps in approved containers. Knowledge check. Blood glucose meters. A, best practice is to dedicate for each patient. B, if shared, must have a label identifying FDA approval. C, must be cleaned after each use. D, all of the above. Blood glucose meters have been identified as a source of outbreaks. Appropriate use of each type of meter is critical for the prevention of infections. Section 5, Take Action. The last section, or Section 5, is our call to action for your work to ensure injection safety practices are used in your facility. We need you to be the eyes in every single facility in Nebraska and throughout the nation to decrease infections. Take action. Develop a written infection prevention and control plan. Ensure injection safety is part of your risk assessment. Provide new employee and annual re-education. Conduct quality assurance monitoring. Audit point-of-care testing. Do you have a policy which includes protocols for performing finger sticks and point-of-care testing? Is there training and competency validation on point-of-care testing at time of employment and annually? Is there an audit which monitors staff adherence to safe point-of-care testing practices? Are the supplies available to perform safe point-of-care testing and injection safety dedicated to residents or labeled for multi-resident use? If point-of-care testing devices are used with multiple residents, is it cleaned and do you use manufacturer's guidelines? This is an example of an equipment cleaning tool that's used in the nursing home environment. There's several good resources out there for your use, and this tool is available at the link on the slide. 60-second checklists for appropriate blood glucose meter monitoring are available at the link on the slide. There's one on insulin pen safety, finger stick lancing devices, and blood glucose meter safety. The Roadmap to Controlled Substance Diversion Prevention is a complete toolkit for drug diversion prevention and includes policies and audit tools. We have asked that you routinely evaluate your injection safety process. This checklist, developed by the One and Only campaign, is a great starting place. This checklist is available at the link on the slide. You can make your own reprints of it, or they are available for free. Use guidelines. Infection control in healthcare has a long history. The recommendations are not new. The Guideline for Isolation Precautions, Preventing Transmission of Infectious Agents in Healthcare Settings is an important document. This document is easily accessed through the CDC's website. It is over 200 pages long. This guidance document from the CDC includes a section on injection safety. I want to emphasize that this document applies to all healthcare settings. There are additional documents to address minimum expectations for care in general outpatient settings and outpatient oncology settings. There is an accompanying checklist for general outpatient setting guidance, which is distilled from the original guidance. If you haven't seen these documents and they apply to your current practice, you should read them to determine if your practice follows the guidance. Many physicians in outpatient settings and in private offices think that it does not apply to them, and many have no familiarity with this 2007 document. Help everyone learn appropriate injection safety practices. Here is the CDC website, which is an excellent source on injection safety and provide many of the resources that we've discussed. The Institute for Safe Medication Practice is also an important guideline which gives us the safe practices when giving adult IV push medications, and the One and Only campaign is an excellent source. It is a national CDC-led coalition made up of healthcare-related organizations, which their whole goal is to promote safe injection practices. There are multimedia resources available, lots of good information. Be sure and access the One and Only campaign. We need you to prioritize prevention. Even though the CDC has prepared a patient notification toolkit, this is something we all hope is never needed. The CDC patient notification toolkit even includes a sample patient letter that disease transmission has been identified and should be issued through your local health department. So, will you take the pledge and ask others in your organization to do so? I will use a new needle. I will use a new syringe for you. This is the one and only time they will be used. Most outbreaks are never detected. There's an asymptomatic infection. You can have hepatitis C for years and never know it. There's an underreporting of cases. There's an under-recognition of this risk in healthcare. There are barriers to investigation and resource constraints to even find outbreaks. The long incubation period where it's difficult to identify where was that initial healthcare exposure. So injection safety is a basic part of patient safety infection prevention program. Outbreaks are very difficult to find and track back to the source. They're very costly to patients, providers, and the healthcare system. They result in patient family anxiety awaiting for test results. So we ask you to make every injection a safe injection. Encourage your patients to voice any safety concerns and consider the consequences for those who contract a preventable infection due to a poor injection practice. Thank you for becoming a safe injection champion. Then we'd like to share with you a final word from Evelyn McKnight, a champion for safe injection practice.
Thank you so much for your commitment to injection safety. It is because of the safe practices of professionals like yourselves that I am a 15-year survivor of the Nebraska hepatitis C outbreak. Your commitment and caring have brought me to this day. In my experiences as being a patient, I have seen the concern in your eyes above your surgical mask and have felt your competency through your latex gloves. Speaking for the thousands of patients that you will care for who will be spared the suffering that 99 Nebraskans endured because of unsafe injections, I thank you from the bottom of our hearts.
After you've completed this program, please take the competency examination. After successful completion of the competency examination, you may apply for continuing education credit. The directions to apply for credit are located on the Nebraska DHHS website where you accessed this program. Again, thank you for becoming a safe injection champion, and do not hesitate to contact the Nebraska DHHS HAI team with questions on this content. I would like to thank the one and only campaign partner states and a variety of healthcare professionals in Nebraska that assisted in development of this program.